Okay, good morning. I'll be presenting a 19-year-old boy from West Bengal who had presented with imbalance while walking, clumsiness of hands for 3 years, change in speech for 2 years, and weakness of both lower limbs for 2 years. He was well till 16 years of age when he first began to notice imbalance while walking, which had progressively worsened. Initially, he had difficulty in crossing narrow doors and riding his bicycle. Later, he began to develop imbalance even while being within a room and needed support to walk. His stance was also difficult. He had clumsiness of hands while writing, feeding, and grooming. His speech had become more slurred than before, and there were shaking movements of the head noted even when he was seated. He had difficulty in getting up from squat due to a feeling of imbalance and some slippage of footwear without awareness. There was no associated thinning, twitching, looseness or tightness of limbs or tripping over objects, no sensory symptoms, no bowel bladder involvement, and normal behavior with affect. He did not have a significant past or a personal history. He was born to non-consanguineous parents, had a younger sister who was well, and there was no such similar illnesses in the family. He was an average student studying in 11th standard. So in summary, it was a 17-year-old boy who presented with progressive imbalance while walking, with incoordination of hands, slurring of speech, excessive movements of the head, associated with slippage of footwear without awareness for 2 years.
A quick question to the audience. What amongst these symptoms cannot be attributed to the cerebellum? The slippage of footwear without awareness, right? That cannot come from anything else? That's the main thing, right? So so we're dealing with something which is more than just cerebellum. Go ahead.
So looking at the localization from the history, the core symptom was imbalance while walking and also clumsiness of hands. So the core symptom is ataxia. It could either be a cerebellar ataxia localizing to the cerebellum and its connections, or a sensory ataxia localizing to the sensory symptom, dorsal column, dorsal root ganglion, or the large fibers. The slurring of speech looked like an ataxic dysarthria, but again needed to be confirmed on examination. There was mild weakness of distal lower limbs, localizing to the motor system, and him not being aware of the slippage of footwear, although he declined any sensory symptoms, whether there was an additional sensory involvement also needed to be clarified on examination. On general examination, there was no ichthyosis, thickened nerves, scleral abnormal vessels, or tendon xanthomas. His higher mental functions were normal. His fundus was normal with normal acuity. His eye examination was normal with, he had an ataxic dysarthria. Motor system examination, there was scoliosis and pes cavus with mild distal weakness in the feet. Sensory examination, joint position sense was reduced in the toes and ankles with reduced vibration in the ankles and toes, with rhombus sign being positive. He had sluggish deep tendon reflexes in the upper limbs and absent reflexes in the lower limbs. Superficial reflexes were normal, plantars were flexors, and he had some cerebellar signs, which I'll be showing. This is a video of his eye examination. Fixation is normal. There is no nystagmus. Pursuits are intact. And extraocular movements are full.
So what part of the cerebellum is relatively intact?
The vestibular cerebellum is relatively spared. We can see that he has a scoliosis. His stance is wide-based. And he has an ataxic gait.
Why do these patients have a scoliosis in these childhood disorders? Because of the imbalance of the musculature in the back.
The trunk as well, yes. Okay, the audio is not clear. So he had an ataxic speech as well. This is a demonstration of the check reflex, which is abnormal.
Also known as?
The rebound phenomenon.
Of? Gordon
Holmes.
Gordon Holmes.
Rapid alternative movements, dysdiadochokinesia, which was present on both hands. And he also had a pes cavus. So in summary, it's a 17-year-old boy who presented with progressive imbalance while walking, clumsiness of hands, slurring of speech, excessive movements of head associated with distal weakness of both lower limbs, and on examination has axial and appendicular cerebellar signs, a Romberg sign which is positive, sluggish deep tendon reflexes, and minimal distal lower limb weakness.
You was able to you were able to test the rhombus because he's ataxic as well. So he was not. He was able to stand, and then
He was able to stand, but on closing eyes, he's swaying. So this is a good way to summarize the symptoms and the signs. So the imbalance while walking and clumsiness of hands, accompanied by an impaired tandem gait, impaired heel sheen test, impaired finger nose and rapid alternative movements with dysmetria, localizes to the midline cerebellum and the paramedian cerebellum or its connections. The nodding of head, it's also called titubation, localizes to the midline cerebellum or its connections. Slurring of speech, in this case an ataxic dysarthria, localizing to the anterior paramedian cerebellum and its connections. Now, in addition to the cerebellar system, other systems are also involved. So he had slippage of footwear without awareness, accompanied by sluggish deep tendon reflexes, abnormal joint position sense, localizing to the sensory symptoms, either to the large fiber peripheral nerves or a dorsal column or dorsal root ganglion, and mild distal weakness associated with a pes cavus, localizing also to the motor system.
So so this is a good way of putting things. So when you're writing down your findings, and there are multiple findings, it's a good way to write down this: what are the symptoms that you have, what are the signs that support the symptoms. So we start with localization process at the level of symptoms, then further at the level of signs, and then finally try and put everything together. So this is purely the neurological part, but we can add the skeletal deformities also, and all the other things, and then say put together the entire thing. Carry on, Lesley.
So, looking at the cerebellum, the midline cerebellum mainly helps with eye movements, balance, vestibular function, and lower extremity coordination, whereas the hemispheric function helps with motor planning and coordination of complex tasks. And there are accompanying tests which can either localize to midline or to the hemispheric cerebellum. So the eye signs in cerebellar disorders, saccadic intrusions, the videos of which we had seen yesterday, localizes to the midline cerebellum, nystagmus, gaze evoked to the midline cerebellum, and downbeating and rebound nystagmus to the flocculus. So in our patient, the total duration of illness was for 2 to 3 years. Rate of progression was insidious onset and gradually progressive, and the syndrome was of that of cerebellum and its connections with involvement of the peripheral nerve. So in our patient, etiological differentials, we thought of a heredodegenerative cause like Friedreich's ataxia, mitochondrial disorders or Golgi spectrum disorders, metabolic causes like vitamin E metabolism related or Refsum's disease, and toxin exposures as well. So this is just a summary slide looking at the causes of an autosomal recessive cerebellar ataxia. The age cutoff for that is less than 25 years. So one thing to note is autosomal recessive cerebellar ataxias are never pure cerebellar ataxias. As shown here, it's the pure cerebellar ataxias are never there. They're usually associated with other system involvement as well. So depending upon which other system is being involved, we can predict which phenotype and which genes are being involved. So in our patient, we were thinking more of a FXN, which is frataxin gene-related Friedreich's ataxia. And if there is associated polyneuropathy, then we can think about other specific diseases. And if there is associated extrapyramidal oculomotor apraxia, we can think of other diseases as well. So I think the take-home message from this is it's never pure cerebellar with other system involvement as well. So in summary, we obtain history and we get a temporal course, take a good family history and physical examination. We always exclude treatable causes. We look at the mode of inheritance and we see whether it is already matching into any particular described type of phenotype. We always test for Friedreich's first because Friedreich's is the most common type of ARCA. And if that is negative, or if the examination is suggestive very much of an alternative diagnosis, we can go for an appropriate genetic testing. Thank you.
So treatable cerebellar ataxias need to be looked at first. In this patient, because of the very prominent neuropathy, the chance of an autosomal recessive cerebellar ataxia was maximum. And Friedreich's is the prototype for an autosomal recessive cerebellar ataxia. With relation to this, you should know or probably read about Anita Harding, who passed on in 1995, but she changed the way that we look at autosomal recessive and autosomal dominant cerebellar ataxia. So you can look at the contribution of Anita Harding to ataxias. The second thing that you should read about, the story of Dr. N.H. Vadia and spinocerebellar ataxia type 2. This is one of the autosomal dominant. N.H. Vadia and SCA2. You can read about these things, just the story behind them. Thank you.